Hello, I'm Hematologist Oncologist Dr. Tony Talebi, and we're back with Dr. Joseph Rosenblatt, Chief of Hematology, University of Miami, and now we're going to discuss the treatment of chronic lymphocytic leukemia. Thank you.
Well, great to see you, Tony.
Thank you. So let's assume a patient comes to you, they've either had a biopsy of a lymph node or they've been diagnosed with CLL via flow cytometry in their blood. What happens next?
Well, I think at that point, the first thing that a hematologist will do, well, first they may be referred to a hematologist, but once they're referred to a hematologist, the first thing the hematologist will do is to begin to do a physical examination, see if the patient has lymph nodes, see if the patient has an enlarged spleen, and based on that and the results of the blood tests, the hematologist will be able to assign what we call a RAI stage, RAI, named after Conti Rai, a famous hematologist who worked on staging of CLL in the 70s. Once that is done, then the hematologist will probably want to acquire additional information. And that additional information will likely come in the form of flow cytometry. CLL characteristically will display two proteins, CD5 and CD23, on the surface. Flow cytometry is a means by which we label the cell with antibodies to specific proteins and then measure the amount of antibody that binds, so we know how those proteins are expressed on the surface of the cells, and also characterize them for expression of proteins that seem to have prognostic significance or can help you take an educated guess at what the future may bring, called CD38 and ZAP70. Once you've done that, then the patients are likely, depending upon presentation, to have their blood also sent for cytogenetics and what we call FISH, or fluorescent in situ hybridization. What cytogenetics is they just simply determine whether or not there are chromosomal abnormalities in the blood by looking at the spread of chromosomes from dividing cells in the peripheral blood or bone marrow. FISH is a more sophisticated means of doing that, and at looking at specific chromosomes using markers that bind to specific chromosomes. And hematologists can garner a lot of information by knowing whether specific translocations that have prognostic importance in CLL are found, like deletions in chromosome 13, chromosome 11, duplications involving chromosome 12, or deletions in chromosome 17.
I see. What if the patient has no symptoms? He or she is asymptomatic and doing fine. What do you do in that scenario?
I would have to say that the vast majority of my CLL patients are not being treated at any one time. And that's because over half of CLL has favorable cytogenetics and is negative for CD38, negative for ZAP70, and oftentimes never comes to treatment during the course of the illness. And that's why they call it chronic lymphocytic leukemia. So many patients do not require treatment. And we only treat because of symptoms or manifestations that indicate that the disease is galloping away and causing more problems. So the indications for treatment may be severe anemia, worsening thrombocytopenia, platelet counts, refractory autoimmune phenomena related to CLL, like a autoimmune hemolytic anemia or autoimmune destruction of platelets, such as autoimmune thrombocytopenia, that make it so that the red cell count or the platelet count is unsafe, or progression of symptoms involving fevers, night sweats, weight loss, enlargement of the spleen to the point where it's causing early satiety, decreased appetite, or enlargement of lymph nodes that becomes uncomfortable for the patient.
Now, if you do decide on treatment, what chemotherapy do you usually choose?
Well, we have come a long way since the 1970s The historical treatment for CLL was two oral drugs, chlorambucil and prednisone.
Mm-hmm.
They worked very well, but rarely produced complete remissions. But they're very gentle forms of therapy that still can be used in an occasional older patient of CLL who won't tolerate the more effective agents. We learned during the 1970s that a class of agents called purine analogues, and then in the 80s and 90s, and this was well established following several cooperative group studies, that fludarabine is a more effective agent. Was the first member of the class, and there's another now approved for CLL called pentostatin. That fludarabine produces more durable responses with a much higher rate of complete responses than chlorambucil and prednisone, and it can be used as a single agent. But during the past decade and a half, we learned that combining additional drugs with that is of added benefit. At MD Anderson, they demonstrated that combining an alkylating agent, cyclophosphamide, Cytoxan, with fludarabine improved response rates and improved the progression-free survival as well as the rate of complete responses. And then subsequently it was demonstrated that addition of an antibody called rituximab, particularly if it's given together with fludarabine, improve the rate of complete responses to the 20 to 30% range and the overall rate of responses to the 70 to 80% range. If one actually goes whole hog and combines fludarabine, cyclophosphamide, and rituximab together, a regimen also developed at MD Anderson called the FCR regimen, then response rates exceed 90%, and complete response rates begin to approach the 30% range. And that is become the most widely used regimen for treatment of aggressive CLL. I generally will treat my patients either with a combination of Rituxan and fludarabine, if they'll tolerate fludarabine, or with a combination of rituximab, fludarabine, and cyclophosphamide, or so-called FCR. And that would probably be the most frequently used regimen. That's well tolerated. There are some side effects. There can be some hair loss. There can be a predictable side effect are fluctuation in the white blood cell count, and it can drop to levels that predispose patients to infection, and that may require antibiotic treatment in order to forestall serious infection. And fludarabine has some other undesirable side effects that occasionally limit its use, like neurotoxicity, occasionally effects on vision, and occasionally it itself appears to be able to precipitate autoimmune phenomenon like autoimmune hemolytic anemia.
I see. What is this new chemotherapy, bendamustine? What are your thoughts on that?
Well, bendamustine is a wonderfully active agent that by itself has a response rate of over 70%, with complete response rates in the 20 to 30% range. It's relatively easy to give. It can be given 2 days, roughly once a month. It's given intravenously. It is a little bit like giving fludarabine and cyclophosphamide together, because it was an agent that was developed in Eastern Europe, one of the contributions of the communist world to modern oncology, widely used in Europe for decades, and then tested in Western Europe and the United States, and it's been approved for refractory CLL. It is as effective as fludarabine and cyclophosphamide given together, and the reason I think it is that effective is it actually, if you look at the molecule, one part of the molecule looks like an alkylating agent, and the other like cyclophosphamide, and another part of the molecule looks like a purine analog. So part of the molecule looks kind of like fludarabine, and part of the molecule looks like cyclophosphamide. So it probably has this dual mechanism of action. It can produce significant cytopenias, low blood cell counts, so it has to be used with care.
Is there ever a role for radiation in CLL?
People used to irradiate massively enlarged spleens. That was not a well-tolerated procedure. The CLL typically involves the bone marrow, so using, for example, radioactive analogues of rituximab like Bexar or Zevalin is not a good idea because it results in irradiation of a lot of normal marrow. So unless there is a particular lymph node pressing on an area that needs acute attention, there's little or no indication for radiation.
I see. Is there anything, does one's diet need to change, or can one exercise during chemotherapy administration?
We don't know of any dietary interventions that are particularly beneficial in CLL. There is some anecdotal data that suggests that green tea may be useful, and some of my patients are drinking fairly copious amounts of green tea. I have not seen responses yet, but anecdotally there is thought to be some response. The tea may actually be useful in some of the suppressive aspects of CLL. There is data emerging that CLL can cause the elaboration of a molecule called adenosine extracellularly. And adenosine is made by two different enzymes on the surface of CLL, one called CD39, the other CD73. Green tea has ingredients that can block the action of adenosine by interacting with the adenosine receptor, very similar to theophylline, which is used in asthma. And that may actually improve sensitivity to chemotherapy. It's been shown to do that in the laboratory. And it may actually decrease the amount of immunosuppression that the CLL engenders, because adenosine is one of the means by which T cells are rendered, are suppressed.
Interesting. Now, sometimes our patients ask us whether they can work during chemotherapy. Is that possible?
Many patients will not feel particularly well during the 4 or 5 days in which they get fludarabine, although others will feel perfectly well and can go to work right after the infusion. Rituximab takes several hours to infuse, and so a day in which you get FCR is a day that you're likely to spend at least 3 to 4 hours, if not more, in the infusion suite. So that may not be a day in which you want to go to work, okay, or can go to work. On the other hand, if all you're getting is fludarabine, that can be done in about an hour or so, and and as long as you're tolerating the drug, don't have unusual nausea, you should be able to go to work. During a week to about 14 days following the administration of combination chemotherapy, you may have low white blood cell counts. And during that time, many patients feel weak and fatigued, and so they wouldn't be terribly effective at work. And also you're more susceptible to infection. So you may, depending on how you interact with the treatment, you may have a period of 1 to 1.5 weeks a month while you're being treated, during which you are less able to work.
I see. Is one able to have sexual relations with a partner while undergoing chemotherapy?
Sure. Right. There really is no contraindication to sexual relations.
I see. And hair loss is very important, especially to females. Will they lose their hair during chemo?
Patients treated with fludarabine or rituximab alone usually have minimal hair loss. Patients treated with fludarabine, cyclophosphamide, and rituximab may have more significant hair loss, although it doesn't approach the kind of hair loss that you see with, for example, Rituxan and CHOP or regimens that are used for other non-Hodgkin's lymphomas. So it's not as bad.
How do you deal with anxiety and depression in your patients?
Well, at this center we have a wonderful psychiatric liaison service as part of overall thrust to try and treat the entire patient. Many patients will become depressed during cancer treatment. That may be due to the difficulties of treatment themselves, due to the weakness and fatigue that they may feel while they're getting, while their white count is low or while they're getting chemotherapy. They may or may not be depressed about the overall diagnosis of cancer and its implications for their lifespan and their projected longevity and the like. I very often will refer patients to liaison psychiatrists, and a small but definite proportion of my patients may benefit from antidepressants like Zoloft or Prozac and the like. And I would encourage patients to seek psychiatric intervention if they feel like their spirits are dwindling.
What do you tell the family members or children of your patients in terms of support?
I tell most of them that this is likely to be a chronic illness that may play itself out over decades. Many of them I say that we may require treatment during the course of the illness, but it's not unusual for a patient to not require treatment at all. That I'm here for them, and that they can try and rest on the oncologist and try and rather than worry themselves to death by reading everything on the internet. They're encouraged to learn about the disease, but also to ask questions so that they understand their disease better. I tell them that the family member will need support, particularly during treatment, but that the family member is very likely to return to a normal lifespan. Typical patient receiving fludarabine and rituximab will go 2 to 4 years before they need treatment again, or may never need treatment again. So so I try and be as optimistic as I can about the potential for a good outcome.
I see. So once a patient has had treatment, how do you follow them to know whether the disease is getting better or worse?
I usually will follow patients while on treatment, at least on a monthly basis. And then when off treatment, I'll usually follow them every 2 to 3 months with repeated blood cell counts and the like, to try and determine what the effects of treatment and how durable the effects of treatment have been.
I see. So let's say if the disease relapses, means it comes back, how do you treat someone differently if it's come back early versus later, months later?
Well, I think if a patient is what we call fludarabine refractory, that portends a worse prognosis overall. If the relapse has not occurred for a year or so, then one can consider simply reinstituting the original drugs, especially if they were well tolerated. We have a variety of salvage therapies available to us in CLL. They all work relatively well for patients who have failed fludarabine, rituximab, or FCR. The drug pentostatin is quite active. There's another regimen called PCR with pentostatin, cyclophosphamide, rituximab, also very active in patients who failed fludarabine. There are other drugs on the market now that have been approved in recent years. Revlimid, which is a drug used in myeloma as well, will produce responses in up to 50% of patients who have relapsed with CLL. And many of those are very durable and well tolerated therapies. There are other antibodies like Campath or alemtuzumab that are useful in the setting of CLL, also reasonably well tolerated, would have to be carefully administered due to the potential for infectious complications. And then there's a recently approved antibody that produces responses in about 50% of patients with CLL called ophitula, which is similar to rituximab, an antibody directed against a molecule called CD20 on the surface of CLL, and that's present in virtually all CLL patients. It seems to bind a little more tightly than rituximab and a little closer to the membrane, and so it may have an additional mode of action that rituximab doesn't have, which may be the reason why it's slightly more effective.
I see. What does the term Recurs transformation mean?
About 3 to 5% of CLL will actually evolve over the course of CLL to a much more aggressive type of lymphoma. and will begin to act and look like what we call a large cell lymphoma. And large cell lymphomas are really more aggressive lymphomas that require more aggressive treatment, need to be eradicated because the outlook for patients with untreated large cell lymphomas is much more dismal. And with typical survivals being less than 2 years. Now the issue there is that it is more complicated to treat a large cell lymphoma in the setting of underlying CLL because you already have underlying compromise of the bone marrow and a pre-existing malignancy that is unlikely to be eradicated by treatment for large cell lymphoma. So our results with Richter's transformation are not as good as we would like them to be. And if one can get a patient like that into remission, that may be a good indication for consideration of additional measures such as a reduced intensity allotransplant.
I see. I was just getting to that. Is there ever a time for a transplant, and what is a reduced intensity allotransplant?
CLL tends to be a disease of the elderly, which limits the utility of transplant. It's easier to do transplantation involving one's own stem cells that one harvests when the patient is in remission, called an autologous stem cell transplant. But unfortunately, for aggressive forms of CLL, that maneuver does not appear to be as effective as it is in other non-Hodgkin's lymphomas or in Hodgkin's disease. And so we've tried it, it doesn't work, and so we don't do it. What we do know is that if you take somebody else's bone marrow from a first-degree relative or somebody who has a tissue match, similar to so-called matched unrelated donor, that isn't a relative, that can actually help to eradicate CLL, sometimes for good, by what's known as a graft versus leukemia effect, which is an immunologic attack on leukemia by the white cells of the unrelated donor. Unfortunately, these tend to be elderly patients, so we cannot do a typical allotransplant, and so we use a different kind of conditioning regimen that's more gentle, does not completely wipe out the bone marrow, called a reduced intensity stem cell transplant, or so-called RIST. And these reduced intensity allotransplants are just now being tried, but there is a definite plateau in survival that appears to translate into long-term survival for some patients related to complete eradication of their disease. On the horizon is a very interesting therapy that has received a lot of press lately, pioneered by Carl June at the University of Pennsylvania, involving genetic engineering of a patient's own T cells to direct them to recognize and destroy CLL cells. And what Dr. June demonstrated in a very elegant study of only one patient, published in the New England Journal of Medicine, is that he could engineer these T cells, reinfuse them into the patient, that they would expand in the patient in response to CLL, and slowly but surely attack the CLL cells and decrease their number, leading potentially to eradication. So it was nice proof of principle that so-called gene therapy and adoptive T cell transfer into a patient might work. He's now treated 4 patients in this manner, so we're definitely at the beginning of a long road.
I see. Is there ever a time when you feel palliative care or hospice is appropriate for a CLL patient?
I think in an older patient who has exhausted options, perhaps been treated by fludarabine, cyclophosphamide, or FCR, or fludarabine and rituximab, then relapsed and required treatment again, and then maybe be treated by bendamustine or by pentostatin with or without rituximab, and then required treatment again and be treated with alemtuzumab, Campath, or ophitula. If a patient is having progressively more infectious complications, is progressing through treatments, is uncomfortable, is requiring multiple transfusions and having multiple infections and spending more and more time in the hospital, that kind of patient may well be appropriate for hospice.
Right. Well, thank you so much.
Okay.
Thank you for watching. We hope this has been educational for you.
Thank you, Tony.